Welcome, everyone, and thank you for joining us today. I'm Kelly Brooks, coordinator for the Forum of ESRD Networks, and I have, before we begin, just a few housekeeping items to go over. First, please remain muted to minimize background noise and interruptions. You may submit questions at any time using the chat feature, and we will answer them at the end of the webinar. Today's presentation is being recorded and will be posted to the forum website for future reference. A survey link to an evaluation form will be included in the chat and in a follow-up email you will receive after the webinar. We would very much appreciate your feedback. So let's get started. I'd like to introduce Dr. Raman Sam, Vice Chair of the Forum's Medical Advisory Council, who has some introductory remarks. Go ahead, Dr. Sam.
Good afternoon, everybody, and thanks very much for joining. First, a little bit about the forum. The forum is a completely volunteer organization, which many nephrologists and medical directors and others contribute their time. And please visit the website, and you will find a lot of useful information, things like toolkits, how to be a medical director, and other very useful information. Including videos of previous lectures that were given in this series. This lecture series has been named after Dr. Don Maloney, which is highly deserving of this title. Don has contributed so much to the network. He's a past president of the forum. And we really appreciate all that he's done and is continues to do for the forum. Next slide, Kelly, please. So today is the fourth of 9 lectures of this series. Today's talk is about water quality given by Dr. Henner. And, we're almost halfway through this lecture series after today. Next slide. So Dr. Henner is currently serves as the Division Chief of Nephrology at Berkshire Medical Center in Pittsfield, Massachusetts. He serves as the medical director of several dialysis facilities as well. He is a past president of the forum and past chair of the Medical Advisory Council representing ESRD network. So, I had a preview of his talk at the annual dialysis conference. I would have to say it was the best water talk I have heard about dialysis water system. So I'm very excited to hear his talk. And without further ado, I'm going to hand it over to Dr. Henner.
Okay, great. Well, thank you, Dr. Sam. Appreciate that. I'll just share my screen. Okay. Should work. Okay, great. Excellent. So hopefully everyone is seeing my screen now. Oh.
We could, now we can't.
Oh, you can't now? Oh, all right. Sorry about that. I screwed it up. Hang on. Let me get out of there. Okay. All right. Let's try that again. Try share. 2. Okay.
There you go.
I've got it. Maximize that. And all right, here we go. How's that? See it okay?
Yes, perfect.
All right, great. All right, well, thank you. Now, certainly an honor and a privilege to be talking to everyone today about one of my favorite topics, which is dialysis water treatment. These are some of the objectives that we're going to cover today. And I will say that when I do give lectures, I do like to be a little interactive with them as much as possible. I know it's a little difficult in a big group like this that's spread out. However, have your phones ready and your cameras ready on your phone because there will be some polling questions, and I definitely want to hear from everybody. So be actively involved with the discussion today. So I wanted to start with just a brief introduction. I know Dr. Sam talked briefly about this, and Previously, if you heard some of the first webinars, Dr. Howard did a great job, I think, covering this in the first talk on what are the networks, just to review what the networks are and what the forum is. So the ESRD program began in 1972 with the passage of a law. And with that, from that day forward, patients that are on dialysis were able to get Medicare coverage regardless of their age. So very important law that was passed and groundbreaking and really changed everything for our patients from that day forward. But by 1978, it became pretty apparent there had to be some quality oversight of the work that was being done by the dialysis facilities. And so the Social Security Act was amended. And with that amendment became the formation of the ESRD networks. Today, you have 18 networks that are under contract by Medicare, or CMS, which stands for Center for Medicare and Medicaid Services. And the responsibilities of the network include quality oversight, as I mentioned, also collection of data and providing technical assistance to dialysis patients and to dialysis facilities. You should know which network is in your region, but if you don't, here's a map. So you can see the 18 networks. So, be familiar with who your network is and definitely utilize your networks. Great resources within the networks, and they're there to support you and your dialysis facility. Now, the forum of networks, unlike the networks themselves, are not under contract by Medicare, but the forum is a not-for-profit organization. And you can see the mission of the forum is to support and advocate on behalf of the networks to promote methods to improve the quality of care for patients with kidney disease. And you can see here, a little bit more about the forum. And this is how the forum's made up. There's 3 councils that make up the forum. You have the executive directors of all 18 networks that make up the EDAC. And then you have the medical advisory council, which is made up of the medical review board chairs of all 18 networks. And you have kidney patients, actually, that make up the kidney patient advisory council. So patients that are either on dialysis or transplant patients from each network that represent each network and part of the KPAC. The leaders, 2 of the leaders of each of these different councils are part of the board of directors, as well as the officers, at large members and ad hoc members. And together, the forum, these are some of the activities you see listed here. We actually meet with CMS leadership from the Division of Kidney Health on a regular basis. We work with different stakeholders. And one of the big things is that there's resources that each of the different councils works on. And one of those are toolkits. And that's what we're going to be reviewing a little bit today. And throughout this lecture series, we've been talking about some of these great toolkits that are part of the professional toolkits. And you can find these on the forum website. One of them being the Outpatient Medical Director Toolkit. And in the Outpatient Medical Director Toolkit, which you can find on our website for free, anyone could download this at any time. This was updated in 2021, the latest update, and I helped to oversee that update, and I helped with the section on water purification, you can see here. But there are other great chapters as well to take a look at. Governance, there's more, in addition to infection control, what Dr. Brazzi lectured on last lecture as part of the series, emergency preparedness, which you'll be hearing more about. FLOPY, regulatory surveys, etc. So definitely take a look at this. Today we're going to be focusing on water, and let's get to the heart of the matter. So water treatment. So first of all, what makes up your dialysate in your dialysis unit? So mostly water, right? Water is 94%. The acid concentrate, or the bath that everyone talks about, only makes up about 2%. And the base, or bicarbonate, makes up about 4%, but the large majority, 94% of your dialysis solution is water. So why should you care about this? Well, the average person in the United States consumes about 14 liters of water a week, whereas a dialysis patient is exposed to about 360 liters of water a week on dialysis. That's about 90 gallons on your average treatment. Remember that our dialysis patients are also immunocompromised. So exposure of our patients to bacteria, viruses, endotoxins in the water could increase their risk of sepsis, infection, or even death. And chemicals that are added by our municipal water treatment systems, such as chlorine or chloramines, can lead to hemolysis and death to our patients. So very important that we know a little bit about this, and it is a patient safety issue. It's very important to understand. Now, the standards that are used in the United States by CMS is really this standard that was called RD52 by AAMI. And this was released in 2004, so a long time ago, more than 20 years ago, and it's been updated several times since the standards, but CMS has not updated this yet. So we're all beholden in our dialysis facilities, if you're surveyed by CMS or your state surveyors, to these conditions. However, if you use a different national survey organization, they might use a more up-to-date regulation, not regulation, but a more up-to-date AAMI standards, which we'll talk about a little later on. Okay, so our first polling question. So get out your phones. You're going to scan the QR code on the screen and answer our very first question today, which is, who is responsible for the safety and quality of water used for dialysis treatments? Is it your biomedical technician, your nurse manager, your facility manager, or your medical director? All right, well, I see most people have chosen the medical director. Some have chosen biomedical technician. So in fact, it is the ultimate responsibility lies within the medical director. That's your key responsibility. So the medical director is ultimately responsible for the safety and quality of water that's used, even though they might not be directly hands-on, but they have to be responsible and they have to know what's going on. This oversight includes both the chemical quality, the microbial quality, and you really want to make sure your system is able to meet the AAMI standards. So it is up to the medical director to ensure that all product water chemical analysis meets these AAMI parameters. The medical director should be knowledgeable about your system that's installed, and should ensure that it's installed consistently producing AAMI quality water. And if any values exceed these AAMI limits, then the facility staff should be notifying the medical director at any time. Testing may need to be repeated and corrective actions may need to be done. We'll talk more about specifics on this. All right, so now let's talk a little bit about the different components of your water treatment system. So typically your main water treatment is usually reverse osmosis in most water treatment systems. Some use deionization. It's a little less common to be used as the main treatment. Usually DI or deionization is used either as a polisher for your reverse osmosis or as a backup if the RO goes down, but some units do use DI. Everything that happens before that is known as your pre-treatment to prepare the water for your main treatment. And then when we talk about the pre-water treatment system, this is not required by CMS or by Medicare, but rather things that are usually in place to get the water ready for your treatment overall. And then at the end, you have a water storage and distribution loop, which we'll talk a little bit about. Okay, so this is your pre-water treatment system. Usually there's about 3 components you might find here. The first being your backflow preventer, which you can see a picture of here. This is typically required by local plumbing codes, and it prevents back pressure or siphonage to your potable or drinking water supply. So you're trying to prevent the dialysis water from getting into your city water, essentially. Next, you usually have a booster pump, and this is to provide the proper water feed to your system to make sure that the water flows right through that system the way it should. Usually there's a regulator to ensure that the water is not overpressurized. So you want to ensure that you have enough volume of water in the system, you have enough pressure to it, and also that it's the right temperature. Why is that important? Well, typically, we know that cold water is typically more pure than warm water. It's it's got a better purity. However, warm water is more efficient. It flows better through the RO membrane quicker. It mixes better with bicarbonate, and also warm water is easier when it hits the machines to be able to be raised to the right temperature to be able to use for dialysis treatments. So if you're starting out with ice cold water, it's going to take longer and use more energy. So usually it's about 77 degrees Fahrenheit is the optimal temperature. And what a blend valve does is it mixes hot and cold water to get to that temperature that you set it at. And this is typically found in your pretreatment. One thing I do want to note here is you notice there's, in this particular picture, you see this orange label that says emergency shut-off valve. It's labeled V4 here. Everyone in your dialysis unit should know where that valve is. If there's ever a disaster with this water shooting everywhere and getting all over the place, everyone should know that the thing to do at that point is to go in there and shut that valve so that to prevent things from getting even messier, and then call your medical director and biomedical technician to find out what to do next. But everyone should be aware of that. That's important to know. All right, you're set. Now you're getting into the pretreatment here. This is your first pretreatment component, and that's your sediment filter. Typically, you have two options here. You have one, which is a multimedia filter that you see on the left here, and on your right, you can see what's called a cartridge filter. The multimedia filter really, well, both of these actually will remove small particles or silt that's in the water system and protect the components that follow it. There's advantages and disadvantages of each one of these. Your multimedia filter has no filters to replace. That's a nice advantage to it. The problem is it has to be backwashed overnight. So usually, so you got to make sure that that happens. Otherwise, the particles just build up and sit in there, and it's not going to function well. What happens is the particles, as they enter this, enter through coarse material on the top, and as it goes down, it gets a little more finer, goes from coarse to medium to fine particles in the bottom, and that traps your particular matter so it doesn't get into the water system. So when you back flush it, it cleans all that out in the middle of the night. What's important when you're monitoring this is to make sure that this timer that's at the top is set to the right time, because you don't want this going off in the middle of the day and start back flushing while patients are on the machine. No one will like that because the machines will start alarming. They won't work. No one's going to be happy if that happens. So you want to make sure that this timer is set correctly, and that's part of your daily testing log of your system. Very important to always check, double, triple check this after time changes, because that's when it gets really messed up. When you move your clocks forward or back, twice a year, you want to make sure that this timer is corrected that next morning. Cartridge filters don't have a timer on them. They don't require a timer. They can run 24/7. They don't need to be back flushed. So that's a big advantage to these. They just have a filter in them that needs to be replaced. Typically, what you do is you monitor the pressure before you see a pressure gauge, and then the next pressure gauge afterwards. And if that pressure drops by about 15 millimeters of mercury, you know it's time to replace these cartridges. So pretty easy to monitor and use. I do recommend these. I use them in most of my units. They work very well. It is a little more expensive to replace these cartridges than to maintain the others, but you don't have the issue of it back flushing in the middle of the night and the timers and all that. Carbon filters. So this is the most important component of your water treatment system. So pay attention. This is really important. Water municipal systems usually add chlorine or chloramine to the water to prevent harmful bacteria in the drinking water. What's chloramine? Chloramine is chlorine plus ammonia, and it's 3 times more difficult to remove from the water than chlorine. These are both harmful to our patients, both chlorine or chloramine. They can cause hemolysis, which can potentially be fatal. And there have been fatalities in dialysis units affecting multiple patients at the same time. So very important safety component that you're aware of this and you know how to monitor this and that you treat this very seriously. This is the only component of your water treatment system that cannot ever be bypassed because of the safety issues. So remember that. All right, so when we look at our carbon filters, you have 2 options here. You have one similar to our multimedia filter, which is our backwashing carbon. And then you have what's called your exchange carbons you can see on the right-hand side here. I'll start with the left. your backwashing carbon. So what you have is you have a worker, usually a big tank, and then a polisher, and the water goes through your worker first, and then through your polisher. Again, these have to back flush in the middle of the night. They have timers on them. So similar to the multimedia filter, you want to make sure that those timers are set correctly. The exchange tanks work a little bit different. They can run, again, they don't have to back flush. They can run 24/7. Usually they run in series. So you have 3 in series in this picture that are parallel to each other. So the water goes through all 3 of these, and then it goes through the back 3, which are your polishers after that. You want to make sure that you have enough carbon to maintain what's called an empty bed contact time of 10 minutes. That means water is in contact with the carbon for 10 minutes. How do you know that? Well, it's a calculation. And you're supposed to do this calculation once a year at least and post it in your dialysis unit to show that it was done. The medical director should sign off on this and verify that this is done. Here's the calculation. You'll get a copy of these slides and they'll be posted online if you want to look at them after and utilize this. But we do, in my units, we always do this once a year and we post them to make sure that that's there for not only for the surveyors, but also for our own safety. So we make sure, this doesn't change. Why do you have to do it once a year? Because it could change. Your conditions could change. Things do change. The flow could change through your RO, for example. And if that changes, then you might need more carbon in the future. So you want to make sure you always have enough carbon. Now, do you rely on the fact that you have enough carbon? No, you don't rely on that because it's too dangerous if you don't. So instead, what we have to do is we have to monitor this, right? We have to monitor this regularly. How do we monitor this? We measure either the total chlorine level, which includes your free chlorine and your chloramine levels, and we test that down to a level of less than 0.1. That's very important. You want to get less than 0.1. If you test it separately, you do have to test down to chloramine less than 0.1 and your free chlorine less than 0.5. Most units use a total chlorine level of less than 0.1. It's a little easier to test. How often do you test this? You should test it in the morning before you open, always before any patient gets on the machine. And then the beginning of every shift before patients are on. If you don't have shifts, then you check them every 4 hours. So, for example, if you have an acute unit in the hospital, and my acute unit's in the hospital, we check it every 4 hours because there's no set shifts there. You do have to check the staff. Any staff that's involved in this testing needs to be colorblind tested. That needs to be documented for all your staff that are using test strips, and you want to make sure that this is well documented. Best practice here is to do a double checked system, meaning 2 people verify this because it's so important. You have your technician do it, but also an RN will verify it, or vice versa, but both do it. That doesn't mean that one does it, like the technician does it, brings the strip over to the nurse and the nurse signs off on it. That's not what that means. Double check means they both watch this being done. You hold the strip under the water for 30 seconds, both watch it, and then you both verify the result that it's negative and less than 0.1. That's what that means. And that's a true double check and a true safety check. All right, we're on to our second polling question here. We're going to get a little harder here, okay? So you are notified by your charge RN that routine chlorine testing for total chlorine is positive at 0.5 milligrams per deciliter at your first sample port. That's post-carbon worker take. She's double-checked the results with a technician. As a medical director, what action should you order? Should you continue dialysis treatment and continue to check after the worker carbon tank each shift? Should you flush the carbon tank for 15 minutes, then recheck your chlorine? Should you check your chlorine at the sample port after the polisher tank? And if negative, continue to check hourly? Or should you bypass the carbon tanks and order new carbon tanks? So go ahead, get out your phone, scan the QR code, and actually, if you scanned it once, you don't have to scan it again. You can just answer the question. I'm glad no one picked bypass the carbon tanks yet, so that's good. All right, so the correct answer is what most of you chose, which is you want to check after the polisher tank. All right, so here's what happens. So if your first sample port after your worker is positive Then you want to check after your second tank or set of tanks, your polishers, immediately. If that's positive also, you need to shut down. That's it. Your patients aren't safe at that point. You got to take your patients off dialysis. If it's negative, you can continue to dialyze patients, but you need to really check every hour to make sure it stays negative. And you could do that up to a maximum of 72 hours. And you have to get new carbon tanks ordered. Either you rotate the tanks and get new ones ordered if you do exchangeable tanks, or you get your big tanks if you're using your back flushing tanks. If it's greater than 72 hours and you still haven't replaced your tanks, then you got to shut down. So you got to get this done within 72 hours. If you do have any chlorine breakthrough, importantly, notify your medical director. Really important. The medical director needs to be involved with any decision making that takes place and the next steps that are involved. Review your policy and procedures. Make sure you're following it properly. And you do want to investigate at your QAPI meeting what happened and what steps to do and why. Very important. This should be part of your QAPI process. So chlorine and carbon, very important. So important that multiple regulations deal with this within the CMS conditions for coverage and interpretive guidance. You can see these are all the V codes that are all the things you could be cited for from CMS if they're doing a survey at your dialysis unit. Lots and lots of different regulations that deal with this because it's so important. All right, I'm going to ask you one more. This actually is a real case example. This happened locally at my hospital not too long ago. Due to a Legionella outbreak in your area, your city has increased chlorine in the city water, but only to a safe drinking water limit of 4 milligrams per liter, they tell you. Chlorine testing after the worker carbon tank is less than 0.1 milligrams per liter. In addition to notifying the medical director, what should you suggest next? Should you continue to check your total chlorine after the worker tank before each shift? Should you increase chlorine checking to hourly after your worker tank? Should you immediately close the unit and send patients home, or should you check chlorine after the polisher tank only? So most of you have said increase chlorine checking to hourly after the worker tank. That's correct. That would be the proper thing to do. Yeah, keep checking it hourly. Make sure it's still negative. Doing it once a shift, yeah, I wouldn't rely on that because you could easily miss something with that spike. You don't exactly know when that spike's coming of the chlorine, and it can hit at any time. So you want to keep checking hourly to make sure you don't miss something. So very important. And this is a very common scenario. It could happen anytime. All right, so now on to your other pretreatment system components. Here you have your different components that remove scale or hardness from the water, and this is to protect your RO from hardness. Most dialysis facilities will use a salt regenerated water softener. This removes calcium and magnesium, your hardness ions, and exchanges them for sodium. Like some of the other components I mentioned before, this would have to be back flushed and regenerated in the middle of the night. So again, the timer on this is very important. You also have what's called a brine tank, which is filled with salt. You want to make sure that that's filled about 2/3 filled with sodium chloride or salt bags, usually bags of salt that you put in there. You also want to verify that the timer is correct. That's important. And then you have to measure your hardness. It's measured in grains per gallon, and you're supposed to do that twice a day. So that's important. That's part of your daily testing log. If you have an alternative here is a chemical feed system. You can see on the right, this is what I use in all my facilities actually. And what this does is it's an anti-scalic chemical that bonds to your hardness ions, your magnesium and your calcium. It increases the molecular weight so much that it actually gets rejected by the RO and goes down the drain. So it never hits the RO membranes and therefore prevents scaling in your RO membranes. So pretty easy to maintain. If you have something like this, all you have to do is make sure there's enough chemical above this fill line, and you don't have to measure hardness. You don't have to worry about this back flushing in the middle of the night or timers or anything like that. So pretty easy to maintain, probably a little more expensive though. All right. Reverse osmosis. So now we're on to our main water treatment component, reverse osmosis. What is this? So first, before we talk about reverse osmosis, what is osmosis? So osmosis is the movement of a solvent, usually water in this case, across semi-permeable membrane from an area of lower solute concentration to an area of higher solute concentration by diffusion. This is a passive process. Reverse osmosis is the opposite. It's moving that solvent, in this case water, from an area of higher solute to an area of lower solute. So you're going up your concentration gradient. And again, this is going to be an active process because it's going against its concentration gradient and it's going to require energy. And that's what reverse osmosis does. So you have different types of machines. I'm only showing you one type of machine here, but they can look a little different than this. This is just one type of machine that you might see. This is your main water treatment. What you're looking at here are alternating RO machines, and this is a nice idea if you could get this in your unit, if you're able to. Here you have two different ROs. You could run them on both, and they'll alternate automatically. So you go from one to the other. If one ever breaks down, you just shut it off and you go to the other one, no problem. You can take it offline and service it and go back on. So that's a nice way to deal with this and have a nice built-in backup. But most units don't have this. Most just have one big RO or one RO that feeds them. How does this work? It uses hydrostatic pressure and forces water through those RO membranes. And then what comes out the other side is your product water or good water known as your permeate. We measure this in something called conductivity, which is how much that water conducts electricity, which is based on how many ions there are in that water. Okay, and the measurement is called microsiemens. The lower that number, the better, the more pure the water. So closer to 0 is better. Most of these are set at an alarm somewhere around 10 or so. You don't want to get too much more than that. So you set an alarm at 10, and if it exceeds that, it will go off not only on the machine, but out of the nurse's station so everyone knows. And then what happens is the RO will send the rest of that water down the drain if you're exceeding that level, so that the patients don't get exposed to that water that's not pure at that point. Usually these are about 50% recovery rate on an RO, meaning 50% of the water that comes through it ends up being the permeate or good water. The other water that goes down the drain is known as the concentrate. Remember, we talked about this before, but the lower the temperature and pressure, the lower the product flow through these, but the more pure the water will be. You do want to monitor not only your conductivity, but also what we call the percent rejection on these. So if your conductivity, for example, is 10 coming out usually, and say it's starting out at 100, that's a 90% rejection rate. So that's pretty good. So it all depends on what you're starting with, what the city water is, and then what you're ending with after the RO to what your percent rejection is. You do have to maintain these, very importantly. They should be disinfected monthly at least, and they should be cleaned at least quarterly. So for the medical director, very important that the medical director has an understanding of how the performance trends are monitored, how they're detected, how problems are detected before they occur. The medical director should be knowledgeable about the water treatment system itself and should participate in discussions involving how you set your alarm set points. These are all, by the way, this is all in the conditions for coverage for the medical director. And how your set points ensure that you have chemical contaminant compliance. So very importantly. All right, now after your RO, you have a water storage and distribution system. And you have two different options here. For smaller units, oftentimes in the acute setting, you might have a direct feed system where the permeate or product water flows directly into your loop or the dialysis machines. Usually those are portable or small systems. The loop water may be returned to the RO and recaptured to go through the system again, or it may just go down the drain. Either one's possible. An advantage of a direct feed system is it's a less favorable environment for bacterial growth. So in general, produces better quality water for the most part. less contaminants possible. However, not the most efficient system. If you have a lot of machines in a big system, not really practical. So most larger systems or most units will use what's called an indirect feed system, where the RO will feed the water into a big storage tank, and then from the storage tank, the water will flow through your loop. Your treated water is pumped usually by a recirculation pump into a distribution loop and then back to the storage tank. You do want to make sure if you have an indirect feed system that your pump is sized to provide 3 feet per second velocity plus your patient flow requirements. So that's important. You want to make sure that your water is flowing through well enough so that your machines all function properly. So here's just an example of what this might look like. Here's a water storage tank. You do want to size these as small as possible. The larger tanks tend to breed. The larger it is, the more likely you want to breed bacteria. So smaller is better, but you have to have enough storage capacity to hold the water for your system. So usually you want to keep these about 250 gallons or less. Usually they're conical shaped, so the water flows through the bottom into your system. And you usually have an air filter that's on the top that needs to be replaced annually. You do want to have water moving through this constantly. So there's usually a spray mechanism to wash down the top of the tank so water doesn't sit stagnant there. And with your loop disinfection, you also want to disinfect your storage tank, importantly. The distribution pumps, you can see on the bottom here, these are dual distribution pumps that alternate. A good idea to have dual pumps in case one breaks, because if you only have one pump and it breaks, yeah, you're out of luck. Your patients are going to have to come off the machine. So having a dual distribution pumps is nice. If one breaks, you can still operate. And you want to have a continuous circulating loop with no dead ends. You want to avoid right angles. You want to keep that water moving to avoid the formation of biofilm and endotoxins in the water. That's really important. Now, deionization, as I mentioned, can be used as your main water treatment system. It's usually not. Usually it's used as a backup to your RO in most cases. In some cases, it may be used as a polisher for the RO if you want to get really pure water. This is an example in one of my units where we have it used as a polisher, or where the RO feeds into a storage tank, and then the water will flow through these DI tanks. We measure deionization in resistivity, so it's the opposite of your RO measurement, and this is measured in something called megohms. The difference here is you want this number to be high, not low. So the higher the megohms, the higher the resistivity, the better the quality of water. If you use this as a backup, you want to store it dry. And once it's used, you don't want to store it again. If it's used as a polisher, usually it's set up similar to your carbon tanks where you have a worker and a polisher. You want to monitor that resistivity twice a day. And you can see here, you have your worker alarm right here. This is blue little button here. If that starts alarming, if the resistivity falls below a level, usually it's about 1 megohm. If it falls below that, it starts alarming. You can just bypass it by pushing the button. No big deal, because you still have your polisher. And if this is not your main water treatment system, that's okay. The main one, it'll read on your display here after the polisher. Typically, if that falls below about 2, now you got to bypass all your DI. You can bypass the whole thing and the water is going to go down the drain if you don't do that. So you got to bypass it at that point and get your tanks replaced, essentially. These will last a long time. If you run them, if you're running them as a polisher, these will last a significant amount of time, and you probably only have to replace them or exchange them with your regular monthly or quarterly even system. All right, so here is your next question. Your dialysis unit installs a new dialysis water system with dual ROs, storage tank, and DI as a polisher. Your biomedical technicians asked you how often you want water sampled for microbial testing. How should you respond? One option is no microbial testing is required since it's a brand new system. Only test if patients have symptoms of sepsis. Do you test water for cultures and endotoxins initially, and then monthly if negative? You test water initially and weekly for cultures and endotoxins. Then if negative, you can test it monthly. Or do you test your system for cultures and endotoxins daily initially, then weekly after 3 months? give it 10 more seconds. Okay, good. All right, so here's your answer. So new systems, we have a new dialysis system put in place. You want to check them weekly initially until you establish a pattern. Once you establish a pattern, then you can go to monthly testing, unless a greater frequency is dictated by historical data at your institution. Okay, for machines, you want to check at least 2 machines monthly, and you want to check enough machines each month that each machine is tested at least once a year. And you should monitor this. At my QAPI meetings, we actually make sure that we, throughout the year, check and make sure each machine is sampled at least once during that year. You don't want to miss that. It's important. All right, so what are some action levels with your water and dialysate? What are your action levels and when do you have to respond here? So this is according to the RD52 regulations that I mentioned that are part of your CMS conditions for coverage, your 2004 standards, AAMI standards, if you will. So maximal allowable levels are a total microbial count of less than 200 colony forming units per milliliter for your bacterial growth, and an endotoxin level, or LALs, of less than 2. Your action levels are less than 50 for your microbial count, and your endotoxin less than 1. Okay, this is what most of you will be surveyed on in your dialysis facilities based on CMS surveys. However, as I mentioned before, some survey agencies now, if you're using an accreditation agency, might use more strict standards, which I'll show you in a minute. That's for your water. Now, dialysate samples, oops, sorry. Here we go. So these are your AAMI standards. So your AAMI standards were updated in about 2011 initially, after those ones that CMS adopted, and then again in 2014. So this is your AAMI 23500 updated standards that some facilities use. My facilities do use this, and I would recommend these. These are a little stricter. CMS has not yet adopted these, but they probably will in the future. I would expect that. If you look here, it's slightly stricter. So you're for the water on the top, for your microbial count, your maximal instead of 200 is 100, and endotoxins instead of 2 is 0.25, so significantly stricter, with action levels of 50 for your microbial instead of 100, and the endotoxin 0.125, so significantly lower. On the bottom, you can see for your dialysis fluid, it's similar numbers, except for the endotoxin, it's 0.5 and 0.25. If you use ultra pure water, if you want to get to ultra pure water, you'd have to get down to a level of 0.1 for your colony forming units per milliliter, and down to an endotoxin level of 0.03. And not all labs could measure to that level, but some can. All right, so what are some action levels? What if this is positive? What do you do? So one thing you can do is you retest your machine, of course, reviewing your compliance with disinfection and sampling procedures, and also evaluate the microbial data for the previous few months. Like, these are all action levels that you could take. But importantly, you want to always notify your medical director and discuss with your medical director any actions that need to be taken and what to do next. Again, it's the final decision if something goes wrong as to whether to continue dialysis really rests with the medical director. It's ultimately up to the medical director to decide that. This is your last question. So your biomedical technician informs you that on routine monthly testing, the post-RO sample is positive at 100 colony forming units per milliliter. The other samples, including the beginning of the loop, the end of the loop, and the dialysate from 2 machines, are all negative at less than 0.1. What should you do now? Should you do nothing? Wait until your next monthly sampling? Should you retest your post-RO sample, since likely sample port contamination? Should you bypass the RO, hook up DI, and call in biomedical technician to immediately disinfect the RO and the rest of the water treatment system? Or should you retest all samples again and bypass the RO? All right, this is pretty common scenario, and as a medical director, you certainly should be able to understand what's going on here when you get results, so you can act appropriately. Yeah, in this case, the correct response is to retest the post-RO sample because that's the only one that was positive, right? The others are all negative. So likely this is sample port contamination. I would just retest that. You could still run. You don't have to worry about any safety to your patients at this point. You do want to retest it though to make sure it's negative. Now, disinfection is important to maintain your system. Normally, you would want to disinfect your storage tank, your distribution loop. If you have a bicarbonate loop, you'd want to do that as well. And of course, your machines. Very few people use reuse anymore, so not so much of an issue anymore as it used to be. Disinfectants, most dialysis facilities use peracetic acid because that's safe to use on your RO membranes. Bleach is not, but sometimes they do use bleach in your system, which is fine for the loop, but not okay for your RO membranes. So know that. It's okay for your machines, but not okay for your RO membranes. How often? Typically, at least monthly, you want to disinfect everything that we talked about. You want regular disinfection, very important to prevent biofilm from forming. If you just do this when you're having a problem, you're going to get biofilm formation that you'll never be able to get rid of. You're going to have to get rid of the entire system at some point. So you got to be careful about that. And regular disinfection is important. Another way to do this is with ozone. Some systems do have the ability to do that. The nice thing about ozone is there's no rinse required. It just dissipates on its own. Some smaller systems also now have heat disinfection available. Typically, these are used for direct feed systems, rarely used for big indirect feed systems. All right, so I am going to stop here. Here are some references I included if you want a little more information about all this. But I'm going to stop here and answer any questions, and I will stop my share at this point.
Thank you very much. And I think there was one question in the chat already. I'm not sure exactly what the question is, but when you were talking about DIs and measuring DI by resistivity, and what is considered high and what is considered low. I think the question is why exactly, and maybe Dr. Deppner, you can clarify the question a little bit better.
Good afternoon. I just want to say thank you very much for a wonderful presentation. And yes, I guess my question is, and I remember hearing this in the past, and I don't remember, why we measure resistivity for DI purification and conductivity for RO purification. That's all. Thank you.
That's a good question. I'm not sure I'm able to answer that question. It's such a good question. That's certainly, the way, I think it just has to do with the way that these components work. They work a little differently. I think that from what I understand, this is a very rudimentary understanding of this, is DI is actually creates more pure water than RO to such a low level that it would be hard to describe it if you did it in conductivity. It would be like 0.001 conductivity. So, for example, that's why they use resistivity, because it's just easier. It's a normal number or integer. It's not, you're not really measuring numbers that are super small with multiple decimals so as to screw you up. So that was my understanding. I'm certainly not a technical expert on this subject, but more of a regulatory expert, if you will. But certainly defer to my biomedical colleagues on this one. But thank you. That was a great question.
So please feel free to put your questions in the chat, and I think maybe there is another question in the chat, and I'm gonna just read out the question. What is your advice for fellows as they graduate and they suddenly signed up as medical directors in private practice? Basically, how to familiarize themselves with the machines in their facility. I'm guessing nurses are a great resource.
Yeah, no, definitely. Your nurses are a great resource, and your biomedical technicians. Get to know your biomedical technicians and how your system works and set up. Meet with them, go through it in detail, understand the system itself and how it's set up. And just for more knowledge base, I would say, go to the definitely go to the National Forum of VSRD Network's website. There's great resources there. The medical director toolkit is great. Download it. There's also an inpatient medical director toolkit, which I would definitely take a look at, and all the other resources. And these lectures that we're doing, the series was a great resource of some information as well. So definitely, utilize that for your own knowledge going forward. I think it's a great basis to start with, a nice foundation.
And there's another question in the chat by Dr. Rankin. So, what do you expect for water systems as far as if you move to hemodiafiltration? Would there be?
Yeah, no, that's a good question, because for hemodiafiltration to work, it has to be ultra pure, the water. The way that works are most of the machines um, that are coming out, currently there's different ones that are coming out in the United States. They have a built-in water treatment system. Essentially, they're doing the purification within the machine itself. So they utilize your regular water treatment, and they create that ultra pure water within the system itself. So I think that's how that's going to work. Otherwise you would have to ensure that water is ultra pure within the system, which is tough to do, otherwise. So having it within the machine itself makes a lot of sense. They do utilize more water, but they're also a little more efficient. So there's a little bit of a balance there, from what I understand. But it does utilize a little more water. I think that's true. I don't know if it's a lot more, but it's at least a little more water. They do use more water to create that ultra pure water. That's true.
Yes, and Dr. Yaram is mentioning there will be a second dialysis filter to create ultra pure.
Yes. Yeah. That's right.
Yeah. And if no one else has a question, I have a couple of questions. So you mentioned about Legionella and the city warning you that they added chloramine to the water system for the city. Should we expect as medical directors that anytime the city does something like that, we be warned, or does it depend, or
Yeah, that's a great question. So, CMS expects that you keep in contact as medical director with your municipal water treatment supplier, meaning that they understand what your needs are and what, how the patients could be affected by this on a regular basis. Used to require that you sent an actual letter to them and keep that on file. It's probably not a bad idea to do that. And I would suggest doing that probably annually at least, to remind them of what, to keep in contact with you. You should get to know who they are and how to contact them, and they should know how to contact you. However, the question is, do you rely on that? Do you rely on them letting you know when something's happening? Because they may not, right? They may not get it. Like in my case example, even people who are very knowledgeable in the water system within our hospital said that, oh, it's fine because the chlorine's only being raised to 4. No big deal. That's the drinking water limit. No big deal. Safe for drinking water, but not safe for dialysis patients. Our limit is 0.1, right? So we have to be much more safe than that. So how do you deal with that? So one thing I'm doing in my facility, and this is not in the rules or regulations, I'm just telling you, what we're doing, what I'm doing locally. I'm actually in the process of getting this implemented currently, is we're actually testing the tap water. You have to test at a different level. It's not the same level because the city does put some chlorine in the water. But if it's getting above that 4 level, if they're going, to a higher level, you want to know when there's a spike. And if there's a spike in that, then we go to hourly testing immediately. So what we're doing is we're testing with a different strip once a day, at least at the beginning of the day, possibly in the middle of the day as well, to make sure there's no spikes in the tap water. And then if there is, we're increasing the frequency of our testing. I think it's not a bad idea to do something like that. I would recommend it. It's not in the rules or regulations. Someday that might become a standard practice. It's not right now, but that's something that I'm doing locally. But it's a great question.
Thank you. Dr. Landry, did you want to say something?
Yeah, I was just going to add on to what Dave just mentioned too. One of the best things I've ever done, I found over the years as a medical director for a dialysis unit, is to establish communication with the local water department. We're in a reasonably decent sized city, And it takes a little time to get them to really understand and appreciate the importance of what you do from a dialysis perspective. But once they do, you know, we get emails. I get emails every day for water main breaks and different things. So while they may not tell you exactly, here's how much chlorine we put in the water, you at least can know to anticipate some things. And it's been, like I said, a really good relationship that they've contacted me during brown water events and different things, and it's been a lot of help. So I just wanted to mention that. And Dave, because I was stumped myself a little, or more stumped than you were, but I just wanted to share a little information I found online with the resistivity and
Great.
conductivity. That was interesting.
Okay, great. No, thank you. Yeah. I was just sharing my what I was told years ago by my biomedical technician expert who's very smart and much smarter than me about this stuff. But yeah, no, that makes sense what you said there. Thank you. No, I appreciate that. Excellent. Okay, great. Any other questions? If not, we'll turn it back over to Kelly, I think.
Thanks very much.
Excellent. Thank you.
Thank you both so much. I have, excuse me, I've put a link to the feedback survey in the chat for everyone. You'll also receive a follow-up email with a link to the survey as well, and we welcome your comments and any suggestions you may have for future webinars. I've also posted a link earlier to the other webinars in this series, so please consider registering for one or all of them if you have not already. You may not know this, but the Forum is a volunteer-led nonprofit organization with limited financial resources. So if you enjoyed this webinar and would like to see more content from the Forum, please consider making a contribution to our organization. Lastly, if you're not following us on social media, please do. You can help us spread the word about all the Forum has to offer. Thank you again for joining us today, and we hope you have a wonderful evening.